Hi guys, welcome back to another episode of my podcast with Little Pinay Nurse right here. It's your girl, yes. So for today's video, because last time I shared to you my notebook, and this has been like the first time in many years that I have looked at it again. So I just want to share what I have wrote kasi pwede itong makatulong sa inyo to learn some things and to prepare when you are about to come here or if you are about to work as a nurse here in the UK. It's good to know these things para hindi tayo nagmumukhang it's just good to be more knowledgeable because when you have knowledge, you have power and then you'll have confidence, which is really good, right? Like, I think if you know a lot more, then you'll be a bit more confident as well. And that's why I'm doing this. I'm not really an expert. I'm not a clinical nurse educator or something, but I just want to share what I have learned so far and kung ano yung binigay sa akin na knowledge. I want to share it with you guys. It could be different with every trust, but I think the principle is similar anyway. For the Filipino nurses out there who are about to come here or they're just starting, it's good to know these things because these are things that are really common in the ward and you will encounter this basically. I have different topics here actually. Merong news score, hypoglycemia, DNA CPR, enteral feeding, dysphagia awareness calls, pressure ulcer, prevention and management pathway, post-op pain, and opioids. So I'm gonna talk about all those things in the next episode. But for now, I just want to focus first on post-op pain and opioids. Especially when you're in a surgical ward, there would be a lot of pain. Okay, papakita ko lang sa inyo guys what I wrote in there. There's a bit of heart as well. Kasi everything that I do, it's always with a heart. Okay, so there's two different kinds of pain. There's acute pain and chronic pain. And with surgical pains, it's usually acute pain because those are like, open wounds and all that. And of course, we have to give painkillers. And you will know what are the common painkillers that we usually give here in the UK and what are like the contraindications, what are the things that we need to watch out for. So meron tayong tinatawag na analgesic ladder for post-op pain. So what is analgesic ladder? So just imagine that there's a stairs in there. The first one is for mild pain. So that's just the first step. And that includes paracetamol as like the main number one that needs to be prescribed, that should be there unless it's contraindicated for the patient or if the patient is allergic. So far, I haven't seen someone who is allergic with paracetamol. But all you have to look out for is the weight of the patient. If 50 kg and below, they shouldn't be given the full dose of 1,000 milligrams. It should be just 500 milligrams. But the normal people here in the adult side, they're usually more than 50 kg anyway. But, just in case. Usually, minor surgeries will be on the first analgesic ladder. These are like really small surgeries or maybe just incision and drainage or really small one. We usually give paracetamol as the first line of painkillers kasi it's the one with the least side effects. Like basically yung paracetamol wala siyang masyadong side effects. It wouldn't make you feel drowsy or anything. It's like one of the safest that you can give as long as it's not overdose. Aside from paracetamol, you could add ibuprofen, which is like NSAIDs. Non-steroidal, anti-inflammatory, either ibuprofen or naproxen or diclofenac. But there's like local policies in the ward where you can't give if the patient hasn't eaten anything yet because it is usually irritating on the stomach lining. But there was one training that I went to where a pharmacist actually said na kahit hindi pa kumain yung pasyente, it's okay as long as wala siyang history of peptic ulcer disease or any kind of ulcer sa stomach, then you can give it daw. Yun yung sabi na But I think it depends on every different ward. They have their local policies as well. It depends. But me, personally, I don't give it unless nakakain na siya. So there would be like regular paracetamol given 4 times a day, 1,000 milligrams usually per dose. And then you can add ibuprofen as well, which is 3 times a day, usually every 8 hours duration. Aside from that, pag may pain pa rin, then there is a PRN, dihydrocodone, which is a weak opioid, usually 30 milligrams. So PRN is like as needed. It's not gonna be given regularly. It will just be given if the patient has extra pain na parang nabigay mo na yung regular, tapos may pain pa rin, so you can give dihydrocodone as PRN. Usually, you can give it every 4 hours. In my previous trust, we usually give cocodamol. Cocodamol is a combination of codeine and paracetamol. Kung magbibigay ka ng cocodamol, hindi ka na pwede magbigay ng paracetamol because it's already there. It's gonna do overdose now with the paracetamol. In our trust now, we just combine paracetamol and dihydrocodone because it's just basically the same. It is constipating, by the way, so it's good to let the patient know about that, especially if they're gonna go home with it. They can buy some laxatives over the counter, or sometimes yung mga doctor piniprescribe na din nila yung laxatives. But just in case, at least you can advise. Okay, tapos na tayo sa minor surgery and the mild pain. And then we go and move on to the intermediate surgery. So they are expected to have a bit of more pain. Going back to the ladder, so intermediate na siya. So another level na siya of pain. So we have to add more to what was in the first level. So nandyan pa rin yung paracetamol, ibuprofen, but the dihydrocodone can be changed to either morphine or oxycodone because yun yung mga controlled drugs na medyo strong. So usually it's good for moderate to severe kind of pain. What they would prescribe is the morphine immediate release or oxycodone immediate release. Just take note that this is different from the morphine modified release because immediate release is usually on the PRN side kasi it's for like extra pain, and this immediate release is usually like more fast acting. Now, if we move on to the major surgery, which are like the next level again, so of course nandyan pa rin yung paracetamol, ibuprofen, pero they would have a regular kind of morphine. Morphine modified release and oxycodone modified release. Modified release means in a controlled manner siya. So like every hour, it will give like specific analgesic effect as far as I understand. That's how it is. And that's why it's given twice a day only and usually good for 12 hours. The dose is usually 10 milligrams morphine as far as my experience, but you can still give 5. And then for oxycodone, it's usually 5 to 10. 5 milligrams of oxycodone is equivalent to 10 milligrams of morphine. So, yun yung parang same ng strength nila, if you know what I mean. So, paracetamol nandyan pa rin, tsaka yung non-steroidal, which is ibuprofen or naproxen or diclofenac. And then, aside from that, then there's regular morphine. And aside from that as well, if they have extra pain, they can get additional PRN, immediate release morphine or oxycodone. So, merong Oramorph, which is the oral morphine. Meron ding yung immediate release na capsule ng oxycodone tsaka morphine. And yeah, so that's the analgesic ladder that I put on my notes in here. Contraindications for use of NSAIDs. If yung patient is may hypovolemia, renal dysfunction, peptic ulcer disease, asthma as well, kasi pag asthmatic yung pasyente, parang sensitive daw sila to NSAIDs. Diclofenac cannot be given for patients who had hypertension, hyperlipidemia, diabetes, or smoker because of the high risk of MI or stroke. Another option as well that is happening in the ward is the PCA or patient-controlled analgesia. So, basically, yung machine, meron siyang morphine or oxycodone or fentanyl in there. So, there's like a syringe inside connected to the IV line. And then when they press the button, it will give them a small dose of this painkiller. And then they can keep on pressing every 5 minutes until the pain is okay. And it has a lockout of 5 minutes. So, even though they press it several times, within the 5 minutes time, it will not give the dose para hindi mag-overdose yung pasyente. But the standard dose for this PCA for morphine, it's 1 milligram per bolus. So, whenever they press it, it will give them 1 milligram. Sometimes there is a background, 1 milligram per hour, which is maliit lang naman talaga. And sometimes there's no background. But other people could be really sensitive with opioids, morphine and fentanyl and oxycodone. These are like opioids. The main thing that we have to look out for when these patients are having this is their breathing, respiratory rate, because it's a depressant. It can depress the respiratory system. Kaya that's one of the things na we are checking regularly, especially when they have a background with their PCA, they are on oxygen kasi nga it has the effect of having respiratory depression. They would usually have low saturations, kaya they need the oxygen as a support. And yeah, maganda yung may PCA kasi at least they wouldn't be asking for the painkiller every 2 hours, especially those na merong major surgery na ano talaga sila sa pain. Very allergic talaga sila sa pain, kaya they can keep on pressing the button na lang instead of calling the nurses, because sometimes the nurses are busy. They couldn't really, and also giving morphine or oxycodone or opioid, you need to do a double check with another nurse. Kaya yun ang nagkakatagal minsan kasi busy yung ibang nurses din. Like wala kang makuha. You need someone to check with you and to give this medication with you. And we just don't have enough staff sometimes in the ward. If the patient has renal dysfunction or CKD, hindi sila pwede ng morphine. Kasi morphine is very toxic to the kidneys. Mas maganda yung fentanyl kasi medyo kind siya sa kidneys. And then another painkiller as well sometimes in the ward is the epidural infusion. Basically, there's like a bag of bupivacaine plus fentanyl bag, and then it will just automatically be giving a dose directly on the epidural regions. Nakakonect talaga siya dito sa likod, and it's really a good painkiller, by the way. But you have to be very careful. Like, it's not always an option, especially to the wards na hindi masyadong used to the epidural kasi meron siyang mga serious side effects, especially pag tumaas na yung the liquid or the medication goes up, maaapektuhan na yung respiratory niya kasi yung purpose lang talaga niya is from the abdomen down to the lower side. Pag tumaas na siya, mahihirapan na siyang makahinga and all that. Kung may pasyente kang ganun, dapat hindi sila talaga mag-position na flat kasi pag flat sila, usually it would go up. So dapat yung bed nila always talagang naka medyo higher yung sa taas para hindi tumaas. At also, kailangan dapat chine-check always yung site kasi pwede silang maghematoma dyan or di mo alam nagli-leak na pala, and it's like really high risk for infection kasi pag makapasok yan yung mga germs sa epidural, then it's gonna be more like serious. You know what I mean? And usually, kailangan mo din i-check yung pain tolerance nila. Because sometimes, like, the pain, parang wala na silang ma-feel na pain talaga. As in, pain is nothing. Pero yung paghinga nila is parang low na, mababa na. It means na they're having overdose na. So, kailangan mong i-lessen yung dose niya. Kasi pwede mong ma-change eh. You can start with like 5 mils per hour or 6, 7, 8 until 10, I think. Minsan pag they were in pain on the first day, they would usually go up to 10. Pero pwede mo siyang ma-change to 7 if the pain is getting better. Parang wini-wind down mo. I haven't had experience epidural for such a long time now. Nung first year ko dito sa UK, which was like 4 years ago, that was when I was in a busy ward and we were having a lot of epidurals. Pero ngayon, hindi na masyado. We do a lot of PCA, which is safe. Kasi nandyan lang siya sa IV site eh. Hindi siya nasa malapit sa spinal. Another option as well, especially sickle cell patients. A lot of these patients are in pain since they were born. Kaya they are really very specific sa painkillers nila minsan. Like, minsan, you can't really argue with them. They know what they need. Kasi pag sickle cell patients, sometimes they have their normal lives. Pero, pag nagka-crisis na sila, grabe na yung pain nila. And that's why they get admitted because they usually get the subcut of morphine or oxycodone. And usually, it's every 2 hours pag may crisis sila. And mag-a-alarm talaga sila ng 2 hours. And some people or some nurses wouldn't really understand this kasi they think that the patient is just, being dependent with the drugs or parang demanding masyado. But actually, the truth is, they wake up with so much pain. Kaya they don't wait for that anymore. They would just alarm para pag mabigay sa kanila, at least they wouldn't be having the severe kind of pain. Yun talaga ang reason bakit sila usually nag-alarm. Mag-understand na lang tayo, especially if we have sickle cell patients. They really need it. And sometimes when I have a sickle cell patient, I would just give everything kung ano ang demands nila because it's just more on like understanding their situation as well. So yun. And then there's another option as well, which is the patch. So usually those who have chronic pain, they usually come to the hospital with a patch. The common one that I have encountered is buprenorphine patch, and usually it has like every 3 days or every 5 days or every 7 days. And this is a controlled drug. So sometimes patients will come in and they have brought their own patches. You need to put it in the controlled drug cupboard. May brief notes pa ako dito ha. So, brief notes. Paracetamol, good safety record when taken in therapeutic doses. B, NSAIDs, safe for short term. Ibuprofen is preferred as it has the lowest GI risk. Naproxen is usually used for those who have high cardiovascular risk. There are situations where you need to avoid NSAIDs, which is first renal dysfunction kasi it causes deterioration of the renal function. And then hypovolemia and dehydration because due to the low renal blood flow, it may cause acute renal failure. And then unstable asthma because it is worsened by NSAIDs. If they have history of gastric ulcer, gastro bleeding, or if they are 65 years old, or they have a lot of comorbidities, or patients who are even taking anticoagulants, then usually they are prescribed with omeprazole together with the NSAIDs para lower yung GI risk. Diclofenac 150 milligrams per day appears to be associated with excess risk of thrombotic events such as stroke and MI. Okay, fun fact. Now, let's talk about the key facts for opioid analgesics. Morphine is the opioid of choice, at least in our trust. Some other trusts could have a different opioid of choice. It could be oxycodone or something else. And then fentanyl is the second line if morphine is contraindicated, such as if patient is with renal dysfunction, CKD, if they have problems with their kidneys, or if they are elderly. Kasi pag elderly, mas maliit na yung kidneys nila, mas fragile na, kumbaga. And then, pethidine increases the risk of neurological toxicity. Okay, hindi na sikat ngayon yung pethidine. Hindi na siya masyadong nagagamit. Like, I haven't ever in my life here in the UK given pethidine. So, weak opioids such as dihydrocodone is the first line for old age. Haven't really remembered this from before, but okay, fine. That's good to know. So, let's talk about the major side effects of opioids. The first is respiratory depression. Kaya always, pag yung pasyente is prescribed with opioids, they're usually naloxone PRN prescribed as well, just in case. So, in the ward before, I have given, I think, twice already for naloxone. Kasi the patient was very drowsy. I would always check the breathing. If it's like less than 8 of respiratory rate, then usually it's a good candidate for naloxone na. Kasi they're probably having a lot already. And even though it's been like days before, sometimes if the patient is really having so much pain, especially in the ward, we keep giving it on the first day, like every 2 hours constantly. And then sometimes hindi siya mag-e-effect right away. Like mag-e-effect siya the next day. Parang minsan may ganun. And I don't know why is that happening or maybe it's just coincidence. So the next day, parang sabog na sila lahat with all the medications and all the painkillers. Napansin ko lang, but I don't know if it's true. Don't quote me on that, okay? Another side effect is nausea and vomiting. Yes, it's very common. And I think especially with Filipino people, sometimes with genes as well. Like a lot of Filipinos who had surgeries and who had morphine, they're really nauseous and vomiting as well. I've seen a lot of that. And I think if I would go to surgery and I will have morphine, I think I will have nausea and vomiting, like serious nausea and vomiting talaga. The third is urinary retention. And then constipation, this is very common. And this is serious matter na minsan we just take for granted sometimes. Especially if they just came out from surgery and they don't want to move out of the bed. Sometimes the patient will refuse to take the laxative because they will think na it's gonna take effect right away. So what I do sometimes is I explain to them na this painkillers you're having, it's constipating. And kasi sometimes if the patient is already constipated and then they start to take the laxative, sometimes it doesn't take effect right away. Minsan kailangan nila ng stronger na laxative like enema or minsan hindi nag-work yung suppository. Yung last option would be enema, which is really strong laxative and a very embarrassing way of having because the more that it gets built up in the body, the more it's difficult to treat the constipation. And then number 5 here is pruritus, which is like itchiness. Yeah, it's very common. Like a lot of patients who had morphine, they're really having like a lot of itchiness. And some doctors can prescribe chlorphenamine, which is antihistamine, to counteract with that effect. Yeah, I think that's it for today's video. Again, please do not quote me on anything that I have said here. I could have been wrong, but this has been my personal experience and I'm usually right. No, I mean, things could change in every department, every policy could change as well. But at least you have like a basic understanding of the opioids, I hope. So yes, yun guys, and thank you so much for watching my vlog. I will see you on the next vlog and I hope you subscribe to my channel. I now have 17 subscribers. Thank you to my 17 subscribers. But I'm hoping to have 1 million subscribers. Manifest na natin yan, yes! And you will learn a lot more. So make sure to subscribe to my channel. Comment down below if this has been helpful. And I will see you on the next episode. Bye!